Talk about all the issues with cognition and behavior, and we're going to start out with my two colleagues, Dr. Natasha Akshimoff and Dr. Sarah Matson, who, as you know from the other night in our little history lesson, joined us in 2006. And I really don't know quite how to express my gratitude, and I know that's on behalf of all of you, for the enormous number of hours and resources that Sarah and Natasha have devoted to your children. They have never, to this day, asked me for anything in return. And I have a little token of appreciation besides our bottles of wine. Each time when we meet to go over data, one of the highest or biggest challenges is we have to figure out where we're going to get our coffee from. So if both of you might want to come up here, I have a little way of addressing at least that problem as a little compensation for each of you.
Thank you.
So yeah, gift card to Pete's Coffee Shop, my favorite coffee shop in San Diego. And I got a free cup of coffee for each certificate, for each gift card. So, all right. So I think Sarah Matson is going to talk first. So I'm going to just give you a little background on Sarah. If I can find my reading glasses. If not, oh, what the hell, I'll just try to guess. Dr. Sarah Matson is a clinical neuropsychologist. I don't need those, do I? With expertise in behavioral teratology, the study of behavioral birth defects. She is a full professor of psychology at San Diego State University. In fact, she told me when she joined San Diego State, on the scoreboard, she has a picture of "Welcome, Dr. Sarah Matson" at the stadium there, which is actually pretty cool. She is the Associate Director of the San Diego State Center for Behavioral Teratology, which is a campus-wide, internationally recognized center focused on the brain and behavioral effects of prenatal exposure to alcohol and other developmental disorders. She's been conducting neuropsychological and neuroimaging research for over 20 years, and this is something quite remarkable. She's been funded continuously by the National Institutes of Health since 1997, resulting in 95 peer-reviewed publications and 16 book chapters. And before I have her come up, I want to introduce as well, or provide you with the background on Dr. Natasha Akshimoff, who is an associate professor in the Department of Psychiatry in the Center for Human Development at UCSD. She is a pediatric clinical neuropsychologist. Her current research focuses on brain and neuropsychological development, their genetic associations, and how these factors are associated with variations in academic skills in children. She is currently leading a longitudinal study on children who were born significantly preterm as they enter kindergarten. She's also involved in a variety of projects that aim to improve early identification and diagnosis of autism spectrum disorders in children and the behavioral phenotypes associated with rare genetic syndromes. So you can see what a great fit both these individuals are for this group. Dr. Akshimoff is actively involved in autism services, very active player in the clinical community here, and she does pediatric neuropsychological assessments here at Rady Children's Hospital. She teaches seminars on neuropsychological development and developmental disorders and provides clinical and research supervision for graduate students and fellows here at UCSD. So I think they're going to kind of do a tag team presentation. So I think, Sarah, you're going to start. And please be sure that each of you get your bottle of wine. And again, I think a warm round of applause for these two. Thank you.
I'll wait till you're all on stage. Hi, good morning. Thank you all for coming. For those of you who are watching or listening live streaming, you may have noticed that the screen went blank. That's because we're not live streaming the video portion, but only the audio portion. So I'm going to talk to you about our neurocognitive and behavioral assessments that we've been doing over the last few years. This is just a little outline. I'm going to talk about the history of our assessments, although it sounds like you've already heard a little bit of history. Just give you an overview. Really, my goal is to tell you about what our assessments are all about and give you a little bit of an insight into what we've been finding. So here's my history. I want to tell you how grateful we are to be a part of this conference and to be able to meet you and work with your families. And I think I'm speaking for all of us when I say that we really, really appreciate you allowing us to work with your children, getting to know your children and your family. So I thought I'd share my children with you over the timeline that we've been here. So as Paul mentioned, we started in 2006, and that's my daughter Maggie, when she was almost 3. We started with, I'll say that year was a learning experience for us. That was the first time we came. We tried to do assessments, and it was a challenge for us. And we realized that we were coming at it from really perhaps not quite the right perspective. And so we made some changes, and in 2008 we came back with better measures, and we were I feel like we were better equipped. We brought in Natasha that year to start doing some autism assessments, and I also added to my family, and that's Henry when he was 1.5 years, on the bottom there. In 2010 we came back and we continued the assessments we'd been doing. 2012 is when we sort of introduced a little more of our ADHD focus, and that's what we're planning. We're also continuing the assessments in autism and ADHD and other behavioral features this year as well. And so my daughter Maggie is 10.5 now, and Henry is 7.5, and you'll see a couple pictures of them throughout the presentation as well. Okay, so as I said, I'm here really just to tell you about our assessment program, what we're doing, a little bit about the results that we've been finding. Natasha's going to focus a little bit more on some specific results, so I'm really going to give you more of a general overview. And to answer any questions, of course, we're happy to answer questions at any time during the meeting or later. So one of the things we try to do is get a general assessment of general ability. So it depends a lot on the age of the person that we're working with. So for babies, or children up through 42 months, we use a scale called the Bailey Scale of Infant and Toddler Development. We do the DAS, which is a Differential Ability Scale for older children. That's actually what most of the kids are getting right now, and that takes about 45 minutes to an hour. And then we're not doing this year, but in the past we've also used an adult measure called the Wechsler Adult Intelligence Scale. And all of these measures really just give us sort of a broad assessment of ability level, okay? And when we are looking at our other information, we'll just use that information as this measure of general ability. So Natasha's going to talk about this in more detail. We also look at a measure of social and communication ability using this measure called the Autism Diagnostic Observation Schedule. And that we can use pretty much with any age, and it takes about 45 minutes, depending. We use lots of measures of behavior rating. So even for those of you who weren't participating in direct assessment this time, you've probably filled out our questionnaires. There's lots of them, and they're all aimed at getting a picture of your child's behavior, whether it's in the social communication domain or disruptive behaviors. So we asked you to complete lots and lots of questionnaires, and that's the ones that are focused here. And then finally, we do some interviews, and they're focused on adaptive behavior. And also we're using something this year called the Computerized Diagnostic Interview Schedule for Children, and it allows us to ask really about more detailed questions about problem behaviors, and we're interested in those types of behaviors in your children. One of the modules is focused on attention deficit disorder, which I'm going to talk a little bit about. Okay, this is just some of the other measures. So we, as I mentioned, we are working with babies and also adults. We aren't doing any adult testing this time, but we have done some in the past, and we're able to give a more detailed assessment, and that's a list of the measures that we use. So just to tell you a little bit about what we're doing and when we've asked you to participate, and if you're interested in participating later, this is really what it's involved. This year's the first year we're actually doing our assessments here at the hotel. I think it's a little bit more convenient for everybody. If that's not the case, let me know. And so we ask that there's direct assessment where we work directly with your child, and then there's parent assessment, whereas this year it's me with the parents doing interviews, and then you've already completed the questionnaires. We do provide a small financial incentive, and then we try to give you some feedback about what we found in our individual interviews and testing. So we'll give you information about your individual child. And of course, as things get published, we'll provide that more general information about the results as we go on. Okay, so what do I think you just heard a little bit about the natural history of Jacobsen's, and these are some of the things that were previously reported in the literature. So that there's delayed development, including both motor and speech development, that there's mild to severe intellectual disabilities, learning difficulties, and behavior problems. Okay, so those are the things that we're really trying to follow up on. One of the things that I think we all think is important is to try to get more information out there about the behavior and cognitive features that we see. So I'm going to just spend a few minutes talking a little bit about our results that we found so far. And if you have any questions, I'd be happy to. We have, I think, more than enough time. So if you have questions, I'd be happy to address them for you. So I'm going to talk a little bit about our questionnaires that we've asked you to complete this year and over the past few years. And those address some of the more general things like developmental milestones, but then the more specific things like behavior ratings. And then I'm going to take a little bit of time and look at the relationship between those findings and the deletion size. Okay, so I wasn't here for Teresa's talk earlier, so I'm not sure. She may have addressed this, but these are some of the things that we see. So when you fill out our questionnaires, we ask you a slew of questions about your child, lots and lots and lots and lots of questions. And these are some of the things that you've told us. So we see a variety of medical issues in our kids. With blood problems and being hospitalized and taking medications, feeding problems, all sorts of things that we see. Oh, I should say, I guess this is the first slide that has this on the bottom. So what I've done is I've collected data over the years that we've been here, not including this year yet. And so far this is based on 63 people that have participated. So we also ask you about developmental milestones. So when your child goes through these first initial milestones like crawling and eating solid foods and things. So those are what I've put up here is the typically developing general age. And remember, there's always a lot of variability even in normal development. And especially in crawling, a lot of parents say, well, my kid never crawled, went right to walking. And that we see that too. So these are the average ages. I should have brought my glasses up here too. It's easier for me to see the big screen than it is. Oh, that's much better. Thank you. Okay, so we see that there is a delay in our meeting our developmental milestones, pretty much in almost every domain that we looked at. Okay, except perhaps with sitting up. We do have some. When it says not yet, this is a sort of. It could include kids that are too young still, but it also could include kids that even at older ages just have never met this milestone. Like, for example, staying dry during the day has been a big one, okay? We also ask you about school service and special services. And these are the things that we have found from that. So most of the kids are attending school, but also most of them are in special education services. 27% have repeated a grade. 96% are receiving other special services other than special education, and that's things like speech therapy, physical, occupational therapy. 66% of families reported their child had any behavioral problems. 30% said that they had a previous diagnosis of ADHD. 57% had a previous diagnosis of learning disability. And that's my daughter at the science fair, right there. So those were reports on our general background questionnaire. We also gave a questionnaire called the Child Behavior Checklist, which asks about very specific behaviors, and these are the results of that. So we, in the general population, you would expect a score of 50, so it's standardized that way, so the average score is 50. And so here we're seeing some elevations, particularly in social problems, attention problems, and thought problems, okay? Now, again, this is an average of, in this case, 36 cases, and when a score exceeds 70, we say that it's in the clinical range, so it has some clinical significance, something that we would follow up on. But the 65 range is also considered borderline, so we're seeing, pretty dramatic elevations in those three areas. And just as a point of comparison, I told you that in the general population we would expect a flat line at the 50. But many years ago, I tested a group of children with Down syndrome. And I included them here because it's another genetic disorder with known cognitive and behavioral issues. And I just wanted to show you the comparison. And we see sort of the same kind of profile with elevations in social problems, thought problems, and attention. But they're somewhat elevated in the Jacobsen's group as opposed to the Down syndrome group. One thing that the CBCL also gives us is a general look at, these are DSM-oriented scales, so these are a scale that would indicate a particular problem that could be diagnosable upon further evaluation. And so things like attention deficit hyperactivity disorder, affective disorders, which are things like depression, anxiety, some of the externalizing disorders like conduct and oppositional disorder. And so the really high yellow bar is a score within the average or typical range. So you can see that on most of our measures, we have most of our kids in the typical range, which is great news, right? So we're not seeing, we're seeing that most of the kids there aren't concerns, huge concerns in these areas. Okay. We do have some elevations in anxiety, so about 20%, a little bit more than 20% of you reported significant concerns in the domain of anxiety, also in the oppositional domain. Okay, but our biggest, the one that we see sort of the biggest differences in is ADHD. Okay, and that's why we started following this in a little bit more detail. So you can see, we still see about 30% of families are reporting not reporting concerns in this area, but equal numbers are reporting concerns in the borderline and clinical ranges. So we're seeing about a third in each of those three categories. Okay, so that leads us to the question of, is ADHD or attention deficit hyperactivity disorder elevated in Jacobsen's? Okay, so we see that there's elevated rates of ADHD ADHD-related problems reported on the CBCL. As I mentioned, 31% were in the borderline range and 36% were in the clinical range. Okay. The attention problem score, which I showed you a few slides ago, was the highest score reported in the on the CBCL. I actually think that's a typo because I think more than 22% had reported a previous diagnosis, but it is definitely elevated. And 14% reported using medications that were used to treat ADHD symptoms. Okay. We also give another questionnaire called the Disruptive Behavior Rating Scale. We gave that to 30 of you. We've given it to you more this year. And on that, 47% met criteria for ADHD. So again, we're seeing pretty elevated rates of ADHD in your children. 23% met criteria for oppositional defined disorder, and only one child, or 3%, met criteria for a conduct disorder. Okay, so I'm going to switch gears a little bit and talk about some of the relationships that we see between our testing and deletion size. Okay, is there any questions before I go on? Okay. All right, so I started by saying that we give everybody a measure of general assessment, okay? And so that general assessment gives us an estimate of IQ. We get it from a multitude of measures, or I shouldn't say multitude, we get it from multiple measures. And one of the things that Paul told me, probably the first time I met him, was that he really believed that deletion size was related to IQ, and that the larger the deletion, the more impaired the IQ was. And that's exactly what we see. Okay, so we see, and there are exceptions, of course, but as deletion sizes get larger, IQ, or sort of general ability, does go down. Okay, so we see that. You can see this line here is illustrating that in a more general way. And the correlation in this sample is 0.76, which is really quite large. Okay, but this is also, I should caution, it's in a small sample. Okay, there's only 16 people in this sample, and there's definitely some outliers. We have this particular person over here that would probably be considered an outlier. Oh, I never realized this was a little animation. Well, maybe I did. I did it on purpose. Of course, I did it on purpose. It's very nifty.
Kind of, obsessing.
Well, detail-oriented and all. Okay, so let's talk a little bit more. So we also looked at the relationship between deletion size and adaptive behavior, which is another really important dimension of overall ability. And we do see a relationship, but after seeing the strong relationship we saw with IQ, this one's not quite as strong. But it is based on a slightly larger sample. Again, we also have an outlier down here. So there is a relationship, but it's not quite as strong as we see with overall ability level. Then we looked at the relationship between deletion size and general behavior. So there's sort of a summary score on the CBCL that gives you a measure of general behavior, and that's even less strong in terms of relationship. So we do see a relationship. It's probably significant, but it's not as strong as we saw. I think once you see a correlation as strong as the one we saw, then anything after that is a little bit weaker. And even smaller is the relationship with externalizing disorder. And that may be because of the elevations in ADHD. So more of the kids than we would have expected based on the general population are showing these signs of attention and hyperactivity problems. And so because it's more common, it's going to mean that the relationship with deletion size is less strong because more people are showing those symptoms. Okay? But this was sort of a surprise to me. When we look at the relationship with internalizing type behaviors, so this would be more of depression or anxiety type behaviors, and this relationship is actually very, very strong. And so that's something that I think we need to perhaps look into a little bit more. It's not something that we have addressed up until this point. Okay. Any questions so far? I'm happy to answer questions at any time while I'm here. Yes?
Before you were going over the data that showed the outlier, child who had, I think, 11 megabase deletion, but was still, I'm sorry.
I can repeat the question too, but go ahead. I can repeat your question if you want to just try.
Okay. Is that accounting for a child who perhaps was just not cooperative for the assessment? Or is that factored in? Because I know my son in particular is completely uncooperative, especially for new people, and he's quite bright but will often test very low because of that. And so does that take that into account with this?
If it was our opinion that the testing was not valid, we would not include it.
Okay, thank you.
Okay. Any other questions? Okay. So, just to summarize what we've done so far. So we've been continuing our behavior assessments, and we hope to continue them into the future. We feel like they have supported previous reports, but they're also providing much more specific information than what's been previously reported. And especially as our sample grows, as more and more people participate in our studies, I think we'll provide some very, very important information to all families and clinicians as well. We've heard from several families that sometimes when they get a diagnosis, the doctors don't really know what to say, because they don't know anything. And so it's our hope that at least from the behavioral side of things that we can change that, so that we can provide some more information for people who are newly diagnosed. And so one of the things that we've been doing is trying to understand the relation between the size of the genetic deletion and the cognitive and behavioral measures that we have been looking at. And we really feel like this is important information, again, especially for those who are newly diagnosed. So what are we going to do? We're going to keep doing what we're doing, and we're going to really listen and pay attention when you all tell us things, because that's how we are able to expand our assessments or address specific or different questions. So, for example, the relationship between internalizing disorders and deletion size, we haven't looked at that before, and that's something that I think we need to address in a little bit more detail. So we're going to continue our assessments do what we're doing, and we're going to continue to try to get some funding for our research support, or to support our research, so we can keep doing what we're doing, just keep coming back as long as you'll have us. And I'm going to stop by saying, and I hope I started by saying this too, is that we really appreciate being here. We really, really appreciate meeting you and getting to know your families. I mean, we obviously couldn't do it without you. So I'm going to stop there and thank you.